Patients with psychotic depression have double the risk of dying in comparison with patients with non-psychotic depression and higher odds of completing suicide. In this video, let's discuss why it's so important to diagnose melancholic and psychotic depression correctly. Melancholic and psychotic depression have distinct clinical features. In clinical practice, unless the clinician recognizes these specific features, both these types of depression may be managed as major depression generically, and this can lead to a reduced response to treatment. For example, in real-life clinical practice, many patients with melancholic depression may be diagnosed as depression and anxiety. This anxiety, however, may actually be part of a psychomotor change such as agitation. Prescribing an antidepressant in such a scenario can worsen the agitation and can also increase the risk of suicide. For example, Akiskal et al. Said, reports of increased risk of suicidal ideation and/or behavior in some depressed patients treated by antidepressant monotherapy or combinations thereof might be attributed to baseline psychomotor activation or agitation as part of an unrecognized bipolar mixed state. Misdiagnosis may also explain why patients with melancholic depression have a 24.1% decrease in the relative chance of remission compared to patients with non-melancholic depression. Now, when it comes to psychotic depression, in clinical practice, patients may present with features of guilt or somatic complaints and may receive a diagnosis of somatization disorder or OCD or health anxiety. Differentiating obsessions from ruminations and delusions is important, as the thoughts as part of psychotic depression often present as concerns that may be based in reality but completely out of proportion and all-consuming. This can easily be misdiagnosed as anxiety or OCD, and this is borne out in literature as well. For example, according to the STOP PD study, psychotic depression was most commonly misdiagnosed as major depressive disorder without psychotic features, depression not otherwise specified, or mood disorder not otherwise specified. It was quite striking that none of these patients with misdiagnosis were considered to have a psychotic disorder. This finding suggests that the clinicians were missing the psychosis rather than the mood disorder. As a result of misdiagnosis, appropriate treatment may not be implemented. And this is again borne out in the STOP PD study, which showed that only 5% of patients with psychotic depression receive an adequate combination of an antidepressant and an antipsychotic. Missing a diagnosis of psychotic depression has severe consequences. Patients with psychotic depression have double the risk of dying in comparison with patients with non-psychotic depression and higher odds of completing suicide. Hence, it's important for us to recognize the distinct clinical features of melancholic and psychotic depression so that appropriate treatment can be initiated. In this course, further, we will highlight these specific features through case studies, and the specific treatment is outlined as part of management.